So case presentation in the NICE in 2019 in France. And doctor is having the 7 international publication on our credit. So this is all about our Dr. Soumya Mather-Metla. So thank you for the giving time, ma'am. So I am overing to you, doctor. Please kindly present the webinar presentation, ma'am.
Thank you for giving me this opportunity. So today I wanted to talk about role of magnesium in various neurological disorders. We know that we give a lot of supplements to our patients. So when a patient comes with a neurological disorder, is magnesium really necessary for them? I will discuss regarding each disorder and what research or literature has been given regarding role of magnesium in each neurological disorder. So magnesium, it has several functions in the body. It acts as a cofactor for more than 300 enzymatic reactions in the body. It regulates a number of fundamental functions like muscle contraction, neuromuscular conduction, glycemic control, myocardial contraction, and blood pressure. And it plays a vital role in energy production. It's an active transmembrane transport for other ions and synthesis of nuclear materials and also bone development. So what is the daily requirement? It is 420 milligrams for adult males and 320 milligrams for adult females respectively. So about 10% of our daily magnesium requirement is derived from the water we drink. So the rich sources of magnesium are green vegetables, nuts, seeds, unprocessed cereals, and some magnesium is also available in fruits, fish, meat, and milk products. We consume usually less than recommended amount because of the processed foods, demineralized water, and agricultural practices using soil deficient in magnesium for growing the food. So our daily dietary intake, if it is about 360 mg, the absorption is about 120 mg. Okay, so the body's magnesium, it's about 2500 mg, and that gets recirculated in the kidney. So the reabsorption, the filtration by the kidney of magnesium is 2400 mg, and again reabsorption is 2300 mg. So the daily output, which is kidney loss, is about 100 mg. So muscle contains about 6600 mg of magnesium. Bone contains even more. So 260 mg is lost through the fecal matter. So why is magnesium important in nervous system? Because it helps in nerve transmission, neuromuscular coordination, and to protect against excitotoxicity, which I'll discuss in the next slide. So it is found that declined magnesium level in brain initiates excitotoxicity, altered blood-brain permeability, oxidative stress, and inflammation. So in any of the neurodegenerative conditions or neurological disorders, because of this mechanism of magnesium, we find that supplementation with magnesium will add to some benefits to the disease. So as I told you in the picture, 50% of the body store is in skeletal bone, and most of the rest is in muscle and soft tissue. Only 0.3% of our magnesium is located in the serum, of which only 60% is in the ionized. So this is an NMDA receptor. The whole talk which I'll be doing today will be dependent on this mechanism of action of magnesium. So here you can see that this is an NMDA receptor and this is the magnesium. So this prevents the NMDA receptor activity and as such decreases the glutaminergic transmission. You know that glutamate is the cause for excitotoxicity and many neurological or neurodegenerative conditions ranging from Alzheimer's to migraine, everywhere epilepsy, there is excitotoxicity. So this magnesium blocks the calcium channel of NMDA and as such reduces the glutaminergic transmission, as such decreasing the excitotoxicity of the NMDA receptor. So basically it shuts off the NMDA receptor. So the magnesium role we can see in various conditions like traumatic brain injury, status epilepticus, subarachnoid hemorrhage, stroke, intracranial. These all, they have harmful effects due to the blood-brain barrier disruption. So what does magnesium do is, it downregulates actoporin 4. It is, as I told you, it's an NMDA receptor blocker or antagonist, and it increases antioxidant capacity, decreases cytokines and lipid peroxidation. And as such, it maintains the integrity of the blood-brain barrier, and as such, it decreases the brain edema. This is all theoretical. It is not proven yet in human studies, but in animal study, it is proven that it maintains the integrity of the blood-brain barrier. So what are the various magnesium formulations we find in the market is magnesium oxide, chloride. We commonly use this magnesium citrate, gluconate, lactate, and magnesium sulfate. Usually magnesium sulfate is not used in the oral form. This is used in eclampsia and also in some conditions like migraine, sometimes in epilepsy. It has a very less, as in oral form, it has elemental magnesium of only about 6.9 mg. So magnesium sulfate is used as IV. Rest are oral preparations. So I will discuss regarding all these disorders and what is the role of magnesium in all these neurological disorders and how much evidence is there in supplementing magnesium in these disorders. So first and foremost and most important thing is in migraine. So a proposed treatment option for migraine is due to, again, blockade of the NMDA receptor, as I discussed. It is an NMDA receptor is an active contributor to pain transmission and cortical spreading depression. The key metabolic factor in mitochondrial functioning and lowers the membrane permeability, reducing the possibility of spontaneous neuronal depression due to hyperexcitability. So lower levels of magnesium has been reported in serum, saliva, and CSF of individuals with migraine during and between the migraine attacks. So what do the guidelines say? So in chronic prevention, the American Academy of Neurology and American Headache Society published guidelines for migraine and gave magnesium a B rating, indicating that it is probably effective. So there is reduction of migraine days between 20 to 43% across 5 clinical trials reviewed from 1990 to 2016. So magnesium oxide is frequently used in pill form to prevent migraine at the dose of 400 to 600 mg per day. Dosage is very important. Above 400 mg only, it is useful in migraine. So, and also the use of migraine is it can be used in pregnancy also. It is a category A drug, which means that it can be safely used in pregnancy. Even in my clinical practice, in people suffering from migraine, mild to moderate by migraine, if they're planning to get pregnant, or some people have exacerbation of migraine in the first trimester. In those conditions, I always prescribe magnesium to those people. So does it have a role in acute treatment? It can be dosed in a pill form at the same dosage or given intravenously, like magnesium sulfate, as I told you. In migraine, especially status migrainosis with aura, magnesium sulfate works well at 1 to 2 grams. And so this is used in aura with migraine with aura. But the most frequent side effect of migraine when it is used in high doses is diarrhea. And diarrhea and abdominal cramping, but with reduction of dose, it comes down by itself. It is a dose limiting side. So why magnesium is preferred in migraine is, it is first of all its safety profile and lack of serious side effects. This can be used continuously daily by the patient without any much side effects. And it is used alone. I use alone in pregnant patients or younger people or very mild attacks. I use magnesium as a supplement, either alone or I also combine it with preventive medications. So magnesium oxide in tablet form is anyways inexpensive. It does not require a prescription also. And it is a better preventive if they have migraine with aura, menstrual migraine, or in who may become pregnant or in pregnancy. So coming to chronic pain. So what is chronic pain? Pain lasting more than 3 months in any body part, like chronic complex regional pain syndrome, low backache, fibromyalgia, neuropathy, some weight pains. They usually, this is the most common complaint I see in my OPD, chronic pain. So they may present in 20 to 25% of the population. So pain relieving effects of magnesium are again dependent on the blockade of NMDA receptors, these in the spinal cord. So it is thought to produce anti-nociceptive and analgesic effect in patients with chronic pain and has been studied as a treatment target in many studies. So recent study examined that 300 mg of magnesium citrate and 10 mg of amitriptyline were given in 60 women with fibromyalgia and 20 age and sex matched controls over 8 weeks. So it is found that combination of magnesium and amitriptyline reported significant decreased pain across various pain and tenderness, while only magnesium alone also resulted in an improvement in number of tender points and intensity of the fibromyalgia pain. So, though collective data on management of pain with magnesium are modest and controversial, it is recommended to give magnesium in chronic pain IV or oral. Still, we need to know the dosages. Additional clinical trials are needed to achieve a sufficient evidence for efficacy of different magnesium formulations. So beyond pain, magnesium with its physiological NMDA receptor or antagonism, it plays a pivotal role as a mediator in pain comorbidities, and it is a valuable non-drug approach. People who cannot tolerate amitriptyline or do not want to use any medication, they can use magnesium as a supplement to optimize the quality of life. Next, coming to cramps. Cramps, it is a sudden, painful, sustained contraction of skeletal muscle fibers. They usually occur as an isolated phenomena or part of a disease, or they occur due to various metabolic derangements. So, over-the-counter magnesium products are often marketed for prevention of muscle cramps. So, this stems from the efficacy that IV magnesium is used in the prevention of eclamptic seizures. So and also the cause of cramps is magnesium deficiency. So there is a rationale for checking electrolytes when a patient presents with muscle cramps and treating any deficiency. But what about patients who do not have magnesium deficiency and have cramps? So there is lack of substantial data to support the benefit of magnesium supplementation when deficiency is not present. So there were 2 meta-analyses again done. They concluded that magnesium supplementation does not appear to be effective in treatment of muscle cramps without deficiency. But if we have to check for magnesium deficiency in every case of cramp, and if it is deficient, supplementing magnesium will definitely be useful. But both studies did identify that there is some potential benefit for in pregnant women when they're having cramps, even though they do not have deficiency. Supplementing magnesium, there was some relief with the supplementation. Coming to anxiety and depression, and especially these are very common comorbid condition. Their prevalence is very high in the community, and especially they occur. They are coexistent with neurological illness, especially with migraine and other chronic pain conditions. They are again mediated by altered glutamatergic neurotransmission. So magnesium modulates the hypothalamic pituitary adrenal axis along with blocking the calcium influx of NMDA glutamatergic receptors. Again, all of which prevent feelings of stress and anxiety. So it is found in some studies that dietary intake of magnesium was also found to have slight inverse relationship with subjective anxiety scores in a large community-based. There is again a negative correlation between dietary intake of magnesium and depression. That is, lower dietary intake was leading to higher depression. Studies have also observed that lower CSF and serum magnesium levels in individuals diagnosed with depression as compared with healthy controls. Coming to epilepsy. Extracellular magnesium has been reported to reduce spontaneous spikes in seizure activity, again via the NMDA receptor, because NMDA receptor plays a role in epileptic seizures. So decreasing the hyperexcitability or blocking the NMDA receptor will decrease theoretically the seizure. We already know that hypomagnesemia itself can cause seizure activity with severe deficiency. And even in some infants with seizures, magnesium supplementation has been found to be beneficial. in hypomagnesemia in infants with seizures. And we also know that we give magnesium sulfate in preeclampsia and eclampsia conditions. Also in TRPM6 gene mutation, juvenile onset Alport syndrome, where there is status epilepticus and refractory status epilepticus, have also reported therapeutic benefit from administration of magnesium supplement along with antiepileptics. Regarding infantile spasm, a study found that IV administration of ACTH with magnesium supplementation for a 3-week period resulted in significant reduction in seizures compared to ACTH alone. So coming to Parkinson's disease, there is not much evidence in other diseases like Parkinson's, Alzheimer's, but I will quote some few studies which were done. So again, Parkinson's disease is excitotoxicity caused by excessive glutaminergic neurotransmission. It mediates a dopaminergic cell loss seen in Parkinson's disease. So this has again modulators of this excitotoxicity are an area of growing research to prevent or to decrease the Parkinson's disease. So multi-center hospital-based case control study done in Japan found that dietary intake of metals in patients who were found to be within 6 years of onset of PD. The results found that higher magnesium concentrations were associated with a reduced risk of PD. Human research of magnesium concentrations in PD is severely lacking despite growing evidence implicating magnesium in animal studies. So there is a need for more studies in PD patients focusing on magnesium concentrations in order to get a better consensus on relationship between magnesium and PD. Coming to Alzheimer's, again, it's a degenerative neurological disorder that is characterized by synaptic loss and cognitive impairments that include deterioration in learning and memory. Excitotoxicity, neuroinflammation, and mitochondrial dysfunction have all been implicated in Alzheimer's disease. Thus, hypomagnesemia could further impair the neuronal function. So AD presents with accumulation of beta amyloid and tau tangles along with inflammation and atrophy. So a systemic review analyzed 13 cross-sectional studies that included AD patients and healthy controls. The results demonstrated that AD patients had significantly lower magnesium concentrations in CSF and in hair samples. The Path Through Life project found that higher magnesium intake was related to reduced risk of developing mild cognitive impairment and mild cognitive disorders. Again, this has a lot of confounding factors, but this is just a brief study done on just magnesium intake and cognitive impairment. Focusing on magnesium treatment through diet has been shown to improve memory. Coming to stroke. Magnesium's role in ability to affect the vascular function as well as to protect against excitotoxicity by NMDA. So it is again an area of interest in the stroke research community. So most of the research conducted on associated between risk of stroke and magnesium can be found in American, European, and Asian prospective cohort studies. Most of the meta-analysis reviewed found that 100 mg per day increment of dietary magnesium intake provided between 2 to 13% protection against total stroke. So investigations of magnesium levels in stroke patients have suggested an association between low magnesium levels and poor outcomes post-stroke. So a meta-analysis also suggested that magnesium sulfate is able to decrease the risk of poor functional outcome in subarachnoid hemorrhage. This is because magnesium sulfate will prevent the vasospasm in some studies. It has been proven that it reduces the vasospasm in animal studies. So this can be given in subarachnoid hemorrhage and patients had better outcomes. So there is research to suggest use of magnesium to improve outcomes post-stroke. So more research is needed to understand the potential protective role of maintaining adequate magnesium levels in prevention of stroke victims. Coming to traumatic brain injury, again, neuroprotective role of magnesium is due to inhibition of the glutamate, NMDA receptor deactivation, decreasing lipid peroxidation, and free radical production. As such, decrease the edema formation. As we saw, it decreases the blood-brain permeability also and decreases the damage as a result of that. Magnesemia in patients with severe traumatic brain injury is associated with an increase in negative outcomes such as mortality and poor functional prognosis. Coming to ADHD. ADHD is a neurodevelopmental condition characterized by three main symptom domains, including inattention, hyperactivity, and impulsivity. It was found that 95% of ADHD patients examined frequently in hair and red blood cells and blood serum, they had magnesium deficiency compared to healthy children. So activity, we know that activity of numerous neurotransmitters such as dopamine, norepinephrine, and serotonin is also dependent on magnesium. So release of NMDA-induced norepinephrine is inhibited by magnesium. So it was found in a study that vitamin D and magnesium supplementation in children with ADHD was effective on conduct problems, social problems, anxiety size score compared to placebo. But it did not affect the psychosomatic problem score significantly. So we have seen that magnesium has been studied in various neurological disorders, but what are the concerns when using magnesium? As a salt compound, magnesium has interaction with multiple types of medications, including bisphosphonates, tetracyclines, quinolone antibiotics, and proton pump inhibitors, because these may decrease the absorption. This magnesium salt can decrease the absorption of these drugs. And also, magnesium salts are found to have greater risk side effect of diarrhea, especially magnesium chloride, gluconate, and oxide. So it is usually this diarrhea is self-managed and it is not severe. But large doses of magnesium supplementation, more than 5,000 mg per day, like when you're using it for eclampsia or for status migrainosus, they have been associated with magnesium toxicity, which could include hypotension, nausea, vomiting, depression. And if the hypermagnesium is severe, it may lead to muscle weakness, difficulty breathing, and also cardiac arrhythmias and cardiac arrest. So I conclude by saying that amount of quality data and association of magnesium with various neurological disorders, it differs greatly. There is strong data for role of magnesium, especially in migraine, chronic pain, and depression. There is also good potential for magnesium to be used in chronic pain condition as well as psychiatric disorders like anxiety and depression. We do prescribe magnesium now in migraine and these chronic pain conditions, but more research is needed in regards to magnesium effect on epilepsy, including the usage of magnesium as an adjunct. Other disorders like Parkinson's, Alzheimer's would benefit greatly as of now in animal studies, but additional research that include, we have to take because magnesium penetration in blood, crossing the blood-brain barrier, we do not know how much. So via CSF measurements and others, we can probably see the role of magnesium supplementations in these neurodegenerative conditions. Finally, there is some research to suggest a positive effect of magnesium for improving post-stroke outcomes and as an important dietary strategy for potentially preventing stroke, though more prospective studies are needed in this. Thank you. Am I audible? Yes. If there are any questions, you can ask.
Doctor, thank you very much for the nice presentation and explanation of the role of magnesium with the latest references. Doctor, if you have any queries from our fellow doctors, we'll see. And they can text whatever the queries also there. So one query we have, ma'am, this for migraine, what is the exact dosage and how long we have to use this magnesium supplementation?
There are no consensus guidelines or on till when we can use treatment. Usually other migraine medications, preventive medications, we tell a minimum of 6 months. So usually I use migraine as magnesium as a supplement in migraine along with other drugs like beta blockers, or we are giving anti-epileptics like sodium valproate, topiramate. I give as an addition. But after their migraine is well under control, post 6 months, if the migraine is well under control, I slowly taper the preventive medication and I put them on maintenance therapy with magnesium, especially in patients with chronic migraine. And the dosage about 400 to 600 mg per day is our target.
Okay, right, doctor. Thank you. And others, if you have any queries, please text us. Doctor will clarify all the queries. Yeah, doctor, whatever the queries we are receiving further, ma'am, we will bring to you and we will address that queries, ma'am. Ravi Shankar, kindly proceed for the vote of thanks.
Yes, sir. Yes, sir. I, behalf of my team members and my team superiors and my DGM marketing and team Vibronica, sir, convey my warm thanks to all participants for their significant presence of this webinar. And I especially want to thank our special guest speaker, Dr. Mathematical Soumya ma'am, for her vital opinions. Thanks to all and thanks to Vibronica. Thank you very much, sir.
Thank you.